So as you can see here, I've given it a very interesting subtitle, Walking on a Tightrope, because pancreatic cytopathology is very challenging diagnostically speaking. I know Asif has a primary interest in pancreas. A lot of you must be finding is very interesting as well. Very few people know that even before I went into thyroid, pancreas was my major interest area, and I've done a lot of work and published a lot on pancreatic cytopathology. And to this date, I find it very difficult often. And we all know that part of the reason is that we are always concerned, what if we make a false positive diagnosis? So what is tightrope walking? It's also known as funambulism. That's the technical name. And these are really daredevils. What they do, they walk on this tightrope at a significant height. And they are very brave, as you know. Not everyone can do that. They are unafraid. They have nerves of steel. They are very experienced. They know what they are doing. They are walking on a tightrope at a lot of height. They know the hazards and risks. They are aware of the margin of error, which is near 0%. You go down, that's the end of your life. They understand the results of an error, major injury or death. They have good insurance coverage for broken bones. So what am I describing, Shahid? Am I describing this guy walking on a tightrope, or am I describing a pancreatic cytopathologist? So we all know how a treacherous business is doing US guided FNA of the pancreas. So we all already know when we approach the patient with a pancreatic mass, it's a bad diagnosis, because 60 to 80% of the FNAs that we do through EUS will turn out to be malignant, with nearly 90% of them being PDAC, they are pancreatic ductal adenocarcinomas. 100% of the FNAs that are done in the United States, I'm sure here as well, are EUS guided FNA, where you bring the transducer through a flexible endoscope very close to the pancreatic substance, and hence it's not unusual to even sample sub-centimeter cysts and get a good sample. And the other advantage being, again, what I mentioned in thyroid, seeing is believing, so you can actually see the tip of the needle when you obtain the sample. As the pancreas wraps around the greater curvature of the stomach, you can go either through the C of the duodenum or the greater curvature of the stomachs all the way to the tail of the pancreas. And sometimes you can even sample the peripancreatic soft tissue masses or lymph nodes. So that's the advantage. Sometimes the needles, special needles are used. Some are shown here. Shock core needle is something that is often used in our practice, which combines the advantage of giving you an FNA sample as well as these core biopsies. So you can do ancillary testing or molecular testing on these samples as well. So again, I'm repeating myself that pancreatic cytopathology, we find it so tough because we practice under an umbrella of fear factor, just like the television program. We are always concerned, what if we end up with a false positive diagnosis and patient will get a Whipple, which is a horrendous surgery with its morbidity and even in some cases mortality. And as a matter of fact, 2 studies that were published at Hopkins, including one of our own studies, showed that 10% of pancreatectomies, when they're examined in histopathology, don't contain cancer, meaning that 10% of surgeries are done for a false positive diagnosis. But not in every single case of these false positive FNAs, or in these cases where no tumor is seen, you can blame cytopathology, because sometimes the clinician will act on their own instinct, on the imaging findings, and operate on the patient. The treatment of sometimes of intractable obstructive jaundice is pancreatectomy. But in this other study where we analyzed these 10% of Whipple surgeries without tumor, we found out that 1/4 of them, these are the true false positive cases, 1/4 of them actually had a specific type of chronic pancreatitis, the AIP. So that's a very important take-home message, that whenever you have evidence of autoimmune pancreatitis in the form of plasma cells or lymphocytes, it's a multi-system disease, or with already an established diagnosis of autoimmune disease, be very careful calling those cases positive. Once again, not stopping you from making the diagnosis of ductal carcinoma, but have a significantly higher threshold. Clearly, based on our study and other published literature, it has shown that chronic pancreatitis, especially of the AIP type, can contain significant epithelial atypia, which begins to overlap with the atypia seen in well-differentiated ductal carcinomas. As I mentioned, chronic pancreatitis being the leading cause of a false positive diagnosis, we know that in histology we have specific features. It's a burnt out pancreas with hardly any SNR tissue. You have irregularly dilated ducts, and you have islet cell hyperplasia. Even on gross examination, you see that the pancreas has lost its lobulated bright yellow tissue, and you have these gray-white bands of fibrotic tissue with significantly dilated ducts, calcifications, and sometimes this fibrotic inflammatory process may spill outside the pancreas, and you can get a false imaging report that it's an infiltrative tumor which is in the peripancreatic soft tissues. And I've seen in some cases the radiologists may even say it's involving or impinging on the vessels. So those are the instances that you have to be very careful with the imaging findings. I often say radiologist is your best friend when it comes to interpretation of pancreatic FNAs, but this is one area where radiology report can also be misleading. Unfortunately, after having told you everything in histology and gross examination and imaging of chronic pancreatitis, there's nothing in cytology which is diagnostic of chronic pancreatitis. People don't believe when I tell them I've yet to diagnose my first case of chronic pancreatitis. I don't make that diagnosis. If I see inflammatory changes, fibrosis, naked fibroblastic nuclei, mixed inflammatory infiltrate, some dissociated fragments of islet cells, I don't see much SNR epithelium, I would simply describe the changes, and then I will say the above changes may represent chronic pancreatitis in the right clinical radiological setting, because I don't think there is anything specific for chronic pancreatitis diagnosis. And I also firmly believe that chronic pancreatitis is very commonly seen as just an incidental finding in ductal carcinoma. So when you make the diagnosis of chronic pancreatitis, you cannot be absolutely certain there is not a tumor sitting in that setting of chronic pancreatitis. And a lot of people believe, experts in pancreas pathology, that chronic pancreatitis cases have a higher incidence of ductal adenocarcinoma. But this is what I really wanted to show you, the reactive changes in the ductal epithelium. So as you can see here, there is significant loss of polarity in these nuclei. The nice ductal epithelial benign look, the honeycomb look is lost to some extent. Once again, disorganization, some hyperchromasia, slight nuclear size variation, much more crowded appearance of the cells. So these are the changes which are still within the range of what you see in chronic pancreatitis. Remember the 4-to-1 rule of nuclear pleomorphism, that if in the same ductal fragment, if you're seeing a nuclear size variation by a factor of 4-to-1, that becomes diagnostic of a well-diff adenocarcinoma. The nuclear size variation in chronic pancreatitis never gets to 4-to-1 size variation. So that is something very important. And also I don't see any single cells in the background, which is something which also helps with the diagnosis. So in my experience, these changes are still within the range of what you would see the type of ductal atypia within chronic pancreatitis. Imaging helps. At Hopkins, we do a weekly multidisciplinary clinic where we sit across surgeons, radiologists, oncologists, and we discuss difficult cases, and sometimes having a basic radiology knowledge or talking to radiologists can help fine-tune your diagnosis, especially if you are right at the fence of whether it's reactive atypia or ductal adenocarcinoma. But when you're shown the changes on imaging, you can actually cross the line and make a more specific diagnosis of adenocarcinoma. Just quick examples. These are axial CT scan at the level of the pancreas in the enhanced phase. Here you see a vague mass, but upstream to this mass, there is significant dilatation of the pancreatic duct, which happens often. As you can see here in this gross specimen, it will squeeze the duct, the sclerotic mass, leading to dilatation of the pancreatic duct. Here there's a big mass in the uncinate prostate with significant atrophy of the distal pancreas. So these are the changes in borderline cases will help you be more specific in your call. So once again, read the radiology report or have some basic knowledge of radiology, or call up your radiologist to discuss the case. These days, this axial slicing of the pancreas is done at such a high resolution that most places will reconstruct using these axial slicing the coronal image of the abdomen, and then your radiologist can actually rotate these images and show you the extent of the mass, the presence of the mass, and even in this case, you can see significant impingement of the big vessels. So this becomes very helpful to call these cases malignant and ductal adenocarcinomas. So this is a beautiful comparison on contrast of what benign ductal epithelium will look like. Beautifully honeycomb, round nuclei, nicely spaced apart. This is a tiny fragment of ductal adenocarcinoma, and as you can see here, chromatin is a little bit more open, nuclei are enlarged. But most importantly, in order to see all the nuclei, you have to focus up and down. So now you're getting a three-dimensionality to this fragment as opposed to the absolutely flat monolayered arrangement of the ductal epithelium, which you see here. And juxtaposed to this ductal epithelium is another fragment of pancreatic ductal adenocarcinoma. And this was certainly is very easy because you have a beautiful comparison right next to this epithelial fragment with significantly pleomorphic nuclei beginning to be discohesive at the edges. So nice comparison. At Hopkins, we grade our ductal adenocarcinomas. Our clinicians ask us to grade these cancers into well, moderate, or poorly differentiated grades. You basically look at four features: the presence or absence of flat sheets or three-dimensional curved fragments. You look at more intact fragments versus more single cells. You look at the pleomorphism, whether it's subtle, focal versus extensive. And you also look at the chromatin density, whether these are pale nuclei with tiny nucleoli versus hyperchromatic nuclei with macronucleoli. This change is unusual in pancreatic ductal adenocarcinoma, but whenever I see macronucleoli, I always try to exclude metastasis to the pancreas. We see lung metastasis, melanomas in the pancreas also. So again, it's a very simple morphologic scheme to grade the carcinomas. So this is an example of well-differentiated, significant crowding, some pleomorphism, not many single cells in the background, higher magnification, some mucin is seen, intracytoplasmic, something in the background as well, markedly enlarged nuclei, mitotic figure, and pleomorphism. This is moderately differentiated, significant pleomorphism, beginning of having single cells. And this is a beautiful 4-to-1 size variation, a feature you often use in histology, can be applied to cytology as well, more complex architecture and significant hyperchromasia seen. And these are examples of poorly differentiated ductal adenocarcinoma. So for the first time, you're seeing macronucleoli, mitotic figures, extensive necrosis. A majority of the cells are single cells. So these are the features which would help you. In a study that we did, we showed that presence or absence of necrosis doesn't always correlate with the grade. We have seen necrosis in well-differentiated tumors as well. So it's a combination of features that will define the grade of the tumor. So the big question is, why do we grade pancreatic ductal adenocarcinomas? We grade for our own sake. That's the most important thing. And we do grading at many other sites, say for example, liver also, for our own sake, because we want to become more accurate in our interpretation. So let me explain what I mean. When we call something well-differentiated ductal adenocarcinoma of the pancreas, we do an exercise in our mind, and we try to exclude the possibility of pancreatitis-associated atypia. When we call something poorly differentiated, we exclude the possibility of metastasis as inner cell carcinoma, so on and so forth. So it forces us to do a mental exercise in our mind to address all the differential diagnoses. It also optimizes cancer therapy. And this is something which is still not agreed upon by most people, but we have seen that if the cancer is poorly differentiated, it will respond better to neoadjuvant chemoradiation for better resectability 6 months later when a Whipple will be done with margin negative disease. So something that also helps our oncologists. And of course, prognostications, poorly differentiated tumors do poorly. If it's a borderline resectable case, but it's poorly differentiated, surgeons may not do the surgery. There are various WHO recognized variants. I'm not going to go into details of each and every one, but I'll just show you the important one. This is adenosquamous carcinoma. It's rare, but it's quite important because of its association with ionizing radiation. Using the histologic criteria, you should have at least 30% squamous differentiation. The other important thing for us to remember is that it's a very aggressive variant of ductal carcinoma with 9-month survival. If you the typical survival of a usual ductal adenocarcinoma with best possible neoadjuvant chemoradiation resection is 22 months. The tumors which are adenosquamous have only 9-month survival. Also important is if the patient has a history of a lung or a head and neck squamous cell carcinoma, they can metastasize to the pancreas as well. So it's important that we exclude that possibility. So these are examples of adenocarcinoma with squamous differentiation. This one, as you can see, is poorly differentiated adenocarcinoma with mucin. Some keratinizing squamous cells are seen, some are non-keratinizing. So what if this is just a ductal carcinoma with focal squamous differentiation? We know that pancreatobiliary adenocarcinomas have a very high incidence of focal squamous differentiation, and I just mentioned that using the WHO histologic criteria, you should have at least 30% squamous differentiation. So what typically happens in this scenario is that even if you have focal squamous differentiation, you're supposed to mention that in your report, because a study which was published from Johns Hopkins from a radiation oncology department, it was shown that all of them have the same poor prognosis regardless of whether it's less than 30% or more than 30%. It's just that you cannot call them adenosquamous unless you see all squamous differentiation like seen here, with the understanding that pure squamous cell carcinomas do not occur in the pancreas. So again, let me explain. The moment you see squamous differentiation, for example, like in this case, just call it poorly differentiated adenoma with focal squamous differentiation for this reason, poor prognosis. And if you see all squamous, for example, in this cell block, these are the cases which you can call adenosquamous. If you don't feel comfortable, just say adenocarcinoma with extensive squamous differentiation and leave it to the histopathologist to call it adenosquamous. This other important one is the solid mucinous or non-cystic colloid carcinoma. So this is not the adenocarcinoma which would arise in a IPN, for example. They are the solid one, just like the breast or the colonic colloid carcinomas. They tend to be of larger size. For example, at the time of presentation, 6 centimeters the average size. Using histologic criteria, they should have at least 80% extracellular mucin, and we can assess this very easily in our cytologic sample, because you will see those big pools of mucin with the floating fragments of adenocarcinoma. This is of much more interest sometimes to the molecular pathologists also, because it has CDX2 staining, MUC2 staining, and they tend to be associated more often with the intestinal type of IPMNs. 5-year survival is excellent, 57%, as opposed to the typical ductal adenocarcinoma, which only has 12% 5-year survival. And these are the images, as you can see, easy diagnosis, beautiful cytohistocorrelation, abundant mucin, malignant cells correlating beautifully with what we see in histology. Also seen here are numerous signal ring cells, and nicely shown in an FNA aspirate as well. The moment we see signal ring cells, we typically think of bad prognosis, but it's interesting that despite having signal ring cells, they carry excellent prognosis. And don't confuse this with the pure signal ring cell carcinoma of the pancreas, which is a totally different entity. It's rare, and whenever you suspect that diagnosis, exclude possibility of metastasis from a gastric signal ring cell or a breast lobular, which are much more common than the pure signal ring cell carcinoma of the pancreas. So this is another WHO recognized variant. The last name or the latest name of this tumor is undifferentiated carcinoma with osteoclast-like giant cell, which is a very nice name because it reminds you that these tumors are quite undifferentiated and they have these multinucleated giant cells. And sometimes they resemble osteoclast very closely, and hence the name. So these tumors sometimes are associated with in situ invasive carcinoma of the usual type, a bad prognosis, just like adenosquamous. Most of the time, the patient will die of the disease within a year. And these are beautiful images from undifferentiated carcinoma with osteoclast-like giant cells. As the name suggests, you have these osteoclast-type giant cells with 20 plus nuclei often. These are innocent bystanders. There's reactive histiocytes, and the malignant component actually is in the background, these mononuclear high NC ratio cells. If you make a cell block, you can see that a M56 or CD68, whichever stain you do, is staining the lymphocytes in the background. And if you do a cytokeratin, then you can see cytokeratin faintly staining the mononuclear malignant cells. So it's important that we know the differentiation of what is reactive here and what is neoplastic. Again, important thing being the dismal prognosis, most of the patients dying of the disease within a year of your FNA diagnosis. As opposed to this previous entity, there is a pure anaplastic or undifferentiated carcinoma, just like lung or thyroid and other sites that we typically report such tumors. Highly malignant. I think it's one of the deadliest tumor of human body. Most of these patients, when you do the FNA and make the diagnosis, already are stage 4 with widespread metastasis. The most important thing to consider when you are making this diagnosis is to exclude metastasis to the pancreas. It's a rare tumor. I don't see more than 1 or 2 cases a year, despite having a very busy pancreatic oncology center, Johns Hopkins. It's very rare, and every time I get excited that I have an anaplastic carcinoma, it ends up being a patient with a history of melanoma or some other tumor being metastatic to the pancreas. So they're very active mitotically and also have this granular necrosis in the background. So you can see, as the name suggests, highly anaplastic tumor. Now, acinar cell carcinoma is a totally different group of tumors. It has a very well-defined demographics. It's typically seen in men, typically seen in elderly men, typically seen in elderly Caucasian men. And about, I would say, 15% or more of these cases, 10 to 15%, show what is known as hypersecretory syndrome, because now the acinar cells, rather than to secrete exocrine enzyme in the pancreatic ducts, these are defective cells. They lose the polarity and begin to secrete the enzymes into peripheral blood, leading to a constellation of symptoms such as peripheral blood eosinophilia, arthritis, non-bacterial endocarditis, peripheral and subcutaneous fat necrosis. So if you have some or all these symptoms in an elderly man, you can suspect acinar cell carcinoma. How common are these tumors? They are rare, significantly rare than compared to ductal carcinoma. Interesting observation is sometimes you see an elevated alpha-fetoprotein in these patients. So if you have a pancreatic mass with an elevated AFP, we know that one of the diagnoses could be pancreatoblastoma, especially in pediatric population, but in adults, it could be related to a patient having an acinar cell carcinoma. The other thing I wanted to mention here is they can show focal neuroendocrine reactivity. So if you have some neuroendocrine markers positive in these tumors, don't think a combined acinar neuroendocrine. It's a diagnosis which is only made when you have at least 25% neuroendocrine component in an acinar cell carcinoma. Important thing is that you diagnose this tumor with accuracy because of excellent prognosis, which is in between a ductal adenocarcinoma and a well-differentiated neuroendocrine tumor. In a study, it was actually placed at almost 57-month survival compared to the 22 months which ductal carcinomas have. Another interesting observation is the big bulky size of this tumor with pushing margins. So if your typical ductal adenocarcinoma, when you make the diagnosis on FNA, is 2.53 centimeter tumor, Your acinar cell carcinoma would be 10, 12, 14 centimeter big, bulky tumors. So then again, all these observations can help you make an accurate diagnosis. And that is how they look like. You have clearly exocrine differentiation, acinar differentiation, except that again, that nice lobulated bunch of grapes-like appearance is lost. And you see also the soft, fleshy appearance on the right-hand side on gross examination. For the trainees sitting here, you can see that in neuroendocrine tumors, you can see that in pancreatoblastoma, you can see that sometime in neuroendocrine tumors, the stroma poor tumors, and sometime in Solid-Pseudopapillary Neoplasm, which are more solid looking, and pancreatic lymphomas. All of them can have this lobulated fleshy appearance. And you can also appreciate the large size of the acinar cell carcinoma. The top one is almost abutting on the spleen, and the bottom ones are also multinodular, but the same pushy margins rather than the infiltrating margins that you see with ductal adenocarcinomas. They often, since they are rich in zymogen granule, just like salivary gland acinic cell carcinoma, they lose their cytoplasm, and you end up with a lot of naked nuclei in the background. Often people confuse these acinar differentiation with the rosette formation of a neuroendocrine tumor, and hence the major differential diagnosis. And it happens all the time. People confuse acinar cell with the pan net and vice versa. I often tell my audience that I sign out pancreatic neuroendocrine tumor without immunoconfirmation all the time, but I never sign out an acinar cell carcinoma without immunoconfirmation because of this issue involved that it can really mimic neuroendocrine tumor and other tumors in the pancreas as well. Sometimes you can even see this vague papillary formation. Sometimes they can look very glandular. But still, the most important differential diagnosis is a neuroendocrine tumor. And this is the point I wanted to mention it to you. If I show these two images to you as unknown, 90% of you will think pancreatic neuroendocrine tumor because of the cellular monotony, because of some suggestion there might be some rosette formations here. Most of the cells are naked nuclei. But these features which I'm showing you are pretty common in acinar cell carcinoma. Luckily, we have good stains. They stain with trypsin, chymotrypsin, but the most important stain which is used these days is BCL10, strongly positive. And I often tell my residents that when they bring the immuno results back to me, I don't even look at the slide under the microscope. I just look at BCL10, okay, positive, next case, acinar cell carcinoma. I've yet to see a neuroendocrine tumor, some other tumor, primarily in the pancreas, staining with BCL10. So it is the most important stain that could be used to make that diagnosis. So changing gears, talking about endocrine pancreas, in cytology, we simply divide them into well-differentiated and poorly differentiated or high grade. The well-differentiated one are then graded based on Ki67 grading, just like in histology. The high grade one, again, just like in histology, are subdivided into small cell, which look exactly almost indistinguishable from small cell lung carcinomas, and the large cell neuroendocrine carcinomas. So just look at these images, especially the trainees sitting in the audience, because these are best classical features of a well-differentiated neuroendocrine tumor. The first feature which you will see on the left-hand side is hypercellularity. Pancreatic tumors, with the exception of acinar cell and neuroendocrine, tend to have some desmoplasia, so you will never see amazing cellularity, the type you're seeing here. So right away, you know that the first differential based on the amount of cells would be a neuroendocrine tumor because they are stroma poor tumors. When you apply suction, there's nothing which will prevent the cell from getting sucked up into the needle. The other feature which you will see here is a tendency to be discohesive. Although there are some fragments seen more intact, but there are numerous single cells. Hypercellularity, discohesion. The third feature you see here is cellular monotony, the uniformity of the cell. They are supposed to be very uniform. Each cell or nucleus will look exactly like its neighboring cell or nucleus. Fourth feature which you see here is a plasma cytoid appearance, which is shown at higher magnification here. And on this diff-quick, the nucleus tend to be eccentrically placed within the cell cytoplasm. And the fifth and the last feature which you see here is the speckled chromatin. As seen here, light and dark spots within the nucleus. Sometimes it's called soccer ball chromatin, sometimes it's called checkerboard chromatin, sometimes people call it salt and pepper, whatever you call it. It's quite classic for pancreatic neuroendocrine tumor, just like in carcinoid tumor. The pancreatic neuroendocrine tumors sometimes have lipid vacuoles in their cytoplasm. I know in histology people like to call them lipid-rich variants of pancreatic neuroendocrine tumor. Sometimes in cytology people get confused when they see a lot of naked nuclei with this very vacuolated smear background, and when they see these intact soap bubble vacuoles within the cell cytoplasm. Well, it's a helpful feature. When you see it in the pancreas, it becomes diagnostic of a pancreatic neuroendocrine tumor. The only differential is if the patient has a history of, say, renal cell carcinoma, which is a common metastasis to the pancreas, you have to exclude that possibility, or sometimes accidental sampling of a adrenal gland can look like that, but if you are, which should not happen in a EUS-FNA. So if I see this feature, the presence of vacuolated background or intact cytoplasm with these soap bubble vacuoles, I would call it pancreatic neuroendocrine tumor, even without confirming immunohistochemistry. For Ki-67, we like to make cell blocks. But the important thing is, even before you do Ki-67, you have to be prepared that you can undercall or overcall Ki-67 grading. You can overcall if there is a chronic pancreatitis in the background, a lot of lymphocytes which may react to Ki-67. You may undercall if there is an extensive GI contamination, say duodenal contamination in the sample. So you really have to find a good sample before you can do the Ki-67 grading. And this is an ideal sample. As you can see here, there are numerous fragments of neuroendocrine differentiation or tumor here. So I would like to find an area which is almost pure. When I do the Ki-67, I like to see the hot spots. So for example, this is a hot spot. I would not count Ki-67 in the entire field. I would only count the Ki-67 in the hot spot. So I would read this particular case, Ki-67 grading of about 80 or 85%. That's how you read it, and then you grade the tumor accordingly. This is a small cell carcinoma of the pancreas. I'm not going to mention the features. They are classic for a small cell, whether seen in lung or Merkel cell, so on and so forth. It's a systemic disease, typically stage 4, and surgery is not done. This was just an odd distal pancreatectomy the surgeon did. Tumor invaded into the spleen. The incidence of primary small cell carcinoma is very low. They are rare tumors. So the way I handle it in my practice is I call it small cell carcinoma in the pancreas, with a note that the possibility of a metastasis from a lung or some other anatomic site, small cell carcinoma, should be excluded. And very often we will go ahead and find a small cell carcinoma in the lung, or patient will be discovered to have a Merkel cell carcinoma. So it's important that we just don't jump to a primary small cell carcinoma diagnosis in these cases. So now finally, cystic neoplasm, then these are very commonly aspirated. At Hopkins, I can tell you on a typical day of sign out, we get anywhere from 6 to 8 to 10 pancreas FNA, and more than half of them are from pancreatic cysts. And I think the biggest role that we play as cytotechnologists or cytopathologists is to diagnose IPMN with the degree of atypia or dysplasia, because studies have shown that one of the most common pre-neoplastic condition in patients who go ahead and develop pancreatic ductal carcinoma is an IPMN. And typically people agree that it's a 10-year period before you would diagnose a high-grade dysplasia till the development of invasive carcinoma. So you have a window of opportunity where you can diagnose these cases of IPMNs with high-grade dysplasia and get them resected, providing a cure to the patient. So it's very important that we realize that. So in terms of what type of lesions we see, I already mentioned the most common one that we see is an IPMN. MCN is very rare on cytology samples, and I don't remember if I ever have diagnosed it. Cyst adenoma is fairly common, and solid pseudopapillary neoplasm as well. So we look at these features, their location, relationship to the dark presence of absent central scar, and the gross appearance of the cyst contents. Our cytotechnologists do 100% of on-site evaluation of our cases, and they record this information. As you can see here, everything is more common in female gender except for IPMNs, which are slightly more common in men. Location may help, but the relationship to the duct is most important. It almost always can be seen on imaging in IPMNs, either with the main duct or the side branch duct. I often have witnessed that when we go and sit in multidisciplinary clinic meetings, pancreas meetings, and if it's my turn as a cytopathologist to show them the features, Shahid, everyone would look at me that I'm presenting the cytomorphology, and I don't have much to show. I mean, there is mucin, there are few cells, so I start to mumble mucin, few cells, macrophages, and people started to yawn. And the radiologists say, I see ductal communication, it's an IPMN, next case. So why do they need us then? They need us for dysplasia, presence or absence of high-grade dysplasia or invasive adenocarcinoma. That is the most important reason. Most of the time, they already know that it's an IPMN. So when you report these lesions, remember, half of the report is the diagnosis, but the second half of the report, which is more important, is presence, absence, high-grade dysplasia. So don't waste your time saying IPMN, low-grade dysplasia, because by definition, all IPMNs have low-grade dysplasia. More relevant is IPMN, negative for high-grade dysplasia or invasive carcinoma. So that is more important. Serous cyst adenoma let me go back and show you, yeah. So serous cyst adenoma is commonly aspirated. Sometimes if the central scar is seen, which is actually seen in majority of the cases, your radiologist may not even do the case because they already know with the scar, which is nicely demonstrated and demonstrable on imaging that it's a serous adenoma. But if there are multiple or if you don't see the scar, then they do the FNA. And they may ask you to evaluate. Unfortunately, it's a very frustrating diagnosis, both for the radiologist and the cytopathologist. For the radiologist, become pass after pass after pass after pass after pass. They will give you watery fluid, nothing else. And you will get frustrated because you keep on telling them non-diagnostic, non-diagnostic, non-diagnostic. So I often tell people when I talk about serous adenoma is that be nice to your radiologist. If it's a sizable lesion and clearly they are sampling the lesion and you end up with nothing but fluid or some cuboidal epithelium non-specific, suggest that this could be a serous adenoma, or send it for fluid analysis. At Hopkins, we routinely do CEA and amylase, and interestingly, they show both low levels, both for CEA and amylase. They don't have any KRAS or GNAS mutations, which are typical for IPMN or MCNs. And if you do VHL, VHL mutation is present in nearly up to 100% of the cases for serous adenoma. So useful piece of information to remember. And also the gender distribution as shown here is more common in female, typically in the elderly age groups, and they tend to be larger. And of course, the location typically is in body and tail and less often in the head or neck. And this is what you would see, non-specific changes, cuboidal epithelium, which would look very benign. In a study which we published many years ago, we showed that most of the time your diagnosis will be descriptive. Most of the time your diagnosis will say non-diagnostic, unless you are really aware that these changes which you're calling non-diagnostic could be from aspiration of a serous adenoma. And the reason is that it's very hard to aspirate this attenuated flat cuboidal lining of serous adenoma. When you put the needle in, you will aspirate the fluid from in between these cellular fragments or papillary fragments. So this is the most important part of my presentation on pancreatic cysts, the IPMN. I already mentioned that MCNs are rarely seen in cytology. And I already mentioned that IPMN is important, thank you, that because it's a pre-neoplastic condition, a pre-malignant condition. So as you can see here, majority arise from the main duct, so hence are located in the head, but sometimes from the branch duct as well. There are various subtypes based on architecture and cell type, which are typically appreciated better on histology. They are classified into low and high grade, and high grade is also similar to the nomenclature of CIS. 1/3 of these cystic lesions have underlying invasive carcinoma. So it's very important that you mention that in your report, negative or positive for CIS or invasive carcinoma, because that will define the prognosis in these cases. Again, studies have shown if you have an IPMN even with high-grade dysplasia, surgery is more than 90% 5-year survival. So it's an excellent prognosis. Cyst fluid analysis is routinely done at all major medical centers. You look for CE and amylase. Since they do communicate with the duct, they tend to have both. CEA is high, amylase is high as well. 192 nanogram per mil is the cutoff that most people agree. If it's higher than 192 nanogram per mil, then it's taken as a strong evidence that you would be dealing with an IPMN. If you do mutational analysis, they tend to show KRAS mutation and GNAS as opposed to MCN, which tend to be GNAS negative. At Hopkins, we don't do the molecular analysis, and we rely more or less on the chemical analysis of the cyst fluid. So this is a typical appearance. If you go and do the on-site evaluation yourself, your endoscopist may show you a markedly dilated ampulla, often exuding mucin. Sometimes you can have that so-called fish mouth deformity. When you make the smear, you will see something which looks like colloid from a thyroid FNA, and you put it under the microscope and you see this thick, impaccated, often crystalline mucin. Once again, looks like colloid aspirated from the thyroid. This is diagnostic. This is enough to call this IPMN. You don't have to have epithelium to call it an IPMN, but if you're lucky, you will see the two components, mucin as well as these papillary-like fragments. The only thing which you can do here is to comment on presence or absence of high-grade dysplasia. So I say so in my report, IPMN, due to lack of cells, I cannot comment on presence or absence of high-grade dysplasia. But keep in mind, this is diagnostic of an IPMN, abundant color like mucin. So I'm showing you example of the absence of high-grade dysplasia in an IPMN. The so-called low-grade dysplasia is almost always there. So mucin secreting cell, abundant clean mucin. I use the word clean because it helps me differentiate mucin from GI luminal contamination, which contains bacteria, many impaccated, degenerated cells. Sometimes the mucin could be thin and watery, very often, and you will not see it on the slide. So big clear zones, ductal epithelium, and again, mucinous epithelium. Literally every cell has a mucin vacuole. So these are all variations to what you would see in an IPMN. My diagnosis will say mucin secreting neoplastic cyst consistent with IPMN in the right clinical radiological setting, negative for high-grade dysplasia and carcinoma. That's how I would report these cases. These are examples of high-grade dysplasia and CIS. Here you see the picket fencing like you would see in a villous adenoma of the colon, significant anisonucleosis, hyperchromasia, and again, very crowded hyperchromatic appearance of these nuclei. So this I would call CIS. A case like this, if you are worried about an invasive carcinoma, there's another creative way of writing your report. You can say IPMN or mucin secreting neoplastic cyst consistent with IPMN, at least high-grade dysplasia. I've seen people doing that because then they are safe if it turns out to be an invasive carcinoma. Your clinicians are intelligent people. They have the understanding that FNA would only sample a small area of the cyst. And if you're calling negative for high-grade dysplasia and carcinoma on resection, they may find invasive carcinoma, which they do 1/3 of the time. So that also teaches us a lesson that it's better not to overcall, not to overreact. I have seen cases, I try to avoid using the term dysplasia in IPM, and Asif, I believe it's a histologic term. So I usually call it high-grade atypia or marked atypia. That's the word I use. And gastroenterologists know that when we say marked atypia, we mean high-grade dysplasia. So casually in a couple of cases, I saw some changes and I wrote IPMN with marked atypia, and I got a call, oh, patient is getting surgery next week. I said, no, I did not call it CIS. They said, well, you called it marked atypia, which we take it as CIS. Remember, when you say marked atypia or high-grade dysplasia, they will do a Whipple. So be very careful. Don't make that diagnosis casually, because they will take it as a serious diagnosis. And again, example of CIS, the intestinal type, the same type of elongated cigar-shaped picket fence nuclei, beautifully correlating with the focus of CIS, which was seen in this particular case of IPMN. So these are examples of invasive carcinoma arising in an IPMN. And in this case, abundant mucin necrosis, high NC ratio cells, macronucleoli seen in majority of these cases, beginning to be discohesive, extremely high NC ratio. And this is one of the cases with correlated with a focus of invasive carcinomas. And these are typically the cases which have presence of significant mural nodule. So why should we say arising in an IPMN? Why can't we just say adenocarcinoma? The reason being that adenocarcinoma which arise in an underlying IPMN have significantly or much better prognosis than the adenocarcinomas that arise de novo. So if I would see something like this, my diagnosis will be adenocarcinoma, which is the more serious diagnosis. And then I would say background changes consistent with or suggestive of an underlying IPMN, which will give useful information to the clinician. So this is the terminology style we use, neoplastic mucinous cyst or mucin-producing neoplastic cyst, consistent with an IPM in the right clinical radiological setting. And then the other important part would be negative or positive for high-grade atypia, which is same as dysplasia or invasive carcinoma. So solid-pseudopapillary neoplasm, I usually call it the resident diagnosis, because residents make that diagnosis. You show them one case, it will take them literally 10 seconds to make the diagnosis. Despite the fact that these are rare tumors, they have such classic cytomorphology. People can sweat on these cases sometime in histopathology, but in cytology it's one of the easiest diagnoses, and I'll show you why. So it's a rare tumor, and we don't know the cellular differentiation in these tumors. They tend to be seen in young females, and as you can see, extremely high female representation here. When they're seen in men, typically they are older age, and these tumors behave much more aggressively. Despite the fact that 10 to 15% are metastatic to the liver often, they still have excellent prognosis, and surgery provides cure in up to 95% of the cases. Again, if you do cyst fluid analysis, just like carcinoma, they tend to have both low CEA and low amylase. They don't have a KRAS GNAS mutation, unlike IPMNs. Very interesting is that if you do further molecular analysis, they tend to have beta-catenin gene mutation. So sometimes that could help with the diagnosis. So this is a very interesting slide. This is based on our observation. We used to call it the Chinese character appearance. I used to have a trainee from China who always used to say, Dr. Ali, the solid-pseudopapillary neoplasm are writings in Chinese character. And I used to say, oh, you are just being nostalgic. You miss being in China. And one day he actually read this off the glass slide and said, it means grains of wheat in Chinese, and actually wrote it for me. So either Chinese characters or Chinese dragons, they have such a classic appearance. It's present in 90+% of the cases because of this perivascular love of these neoplastic cells. They tend to anchor themselves to vascular endothelium, creating these beautiful patterns, and hence it's a very easy diagnosis. The only other tumor which really can have similar architecture, not exactly similar, but a little bit perivascular, are occasional cases of pancreatic neuroendocrine tumors. But otherwise, best diagnostic of solid-pseudopapillary neoplasm. And that's the reason why they create these patterns, because of the stickiness of these neoplastic cells in multiple layers to the vascular endothelium. I once had a observer, a pathologist from Australia, who worked with me for a few months with a major interest in pancreas, and he did a project in which he counted that average thickness of the layers of these cells is 7. There are at least 7 layers of cells anchoring to this vascular endothelium. But whatever the case be, you can see how beautiful they lead to the formation of these architectural patterns for solid pseudopapillary neoplasm. However, if you look away from the areas where these perivascular patterns are seen, you can find features which will give you an impression that you're in the thyroid and you're looking at a papillary thyroid carcinoma because of the oval nuclei, because of the beautiful nuclear grooves, and because of the intranuclear inclusion. So again, an easy thing to remember is that if you have PTC-like appearance in a pancreatic FNA, think of solid pseudopapillary neoplasm. Another feature which is typically seen on Giemsa stain or Diff-Quick stain, if you do that, would be the presence of these pseudoglandular formations with these hyaline inclusions or hyaline balls within these gland-like spaces. Also a good feature for the diagnosis of solid pseudopapillary neoplasm. So it looks like a solid pseudopapillary neoplasm, same features which I illustrated to you, but look at these cells. They are more plasmacytoid, and this is an INSM1 immunostain. So this is an example of well-differentiated pancreatic neuroendocrine tumor with the same pattern as solid pseudopapillary neoplasm. That brings up a very important point. As I mentioned, I sign out pancreatic neuroendocrine tumor all the time without immunostaining. But for solid pseudopapillary neoplasm, I think it's a good practice to do immunostains. And which immunostains are typically done? As I shown here, one stain is beta-catenin, which stains the nuclei as opposed to the membranes or the cytoplasm, which is typically seen in ductal carcinomas or benign ductal epithelium. Or you can do a CD99, which tends to stain the cytoplasm in a granular fashion. So both stains are good. There are several other stains, but I think you can get adequate answer by using just these stains. So what about the role of molecular tests? It's still evolving. At Hopkins, it's typically done on cystic lesions, not in-house, but it's sent to University of Pittsburgh, where one of our former trainees has developed a test which is called Pancreas-Seq, the same group which has developed the Thyroseq test. And they have illustrated certain genetic changes, and it's of value in cystic lesions that's shown here, TP53, SMAD4, P10. Some of these mutations can be seen, and we all know that NGS sometimes can illustrate adequately KRAS, TP53, SMAD4 as well. In neuroendocrine tumors, it has a very limited role, the molecular testing, and this is that Pancreas-Seq genomic classifier, which is done at University of Pittsburgh. It's an elaborate test looking at 74 genes. Again, I would not recommend that you resort to these expensive, elaborate molecular tests because in pancreatic cytology is typically a diagnosis which is based on morphology. So as I promised to you, I spoke with a very loud tone, and I hope no one was taking a nap. So with that, I end this very difficult topic. And I think we will have an early coffee break, and after that, I can do my unknowns. Great, thank you.